you for Dewa for the introductions, and I'm welcome you to come to this little sharing sessions. So I would like to talk a bit and maybe share with you some of the infection and sepsis identification. Today I will focus on how you identify sepsis, and then I will talk about those what is sepsis all about, and also how our body inflammation cause the sepsis, and in which state we need to intervene with a proper management. So I will go into a very quite a fundamental insight on sepsis, how it happens and how it ends. So it will be, you can stop me from any time and you can ask any question from time to time, right? So without so before that, we need to know that what is the definition of sepsis. There is many type of there's a lot of people confused about sepsis from SIRS, from CAS, from qSOFA, all these things. So, however, I will share with you this evolution. Can you see this chart? Okay. This chart actually talking about I've summarized the whole sepsis evolutions definition from since 1970. Year 1970, the word sepsis was start to appear in any books and any critical care management case note. So that time they understand, they only start to use the word multi-organ failure concept was just introduced during this 1980s. And the first time all the critical care people, I tell critical care, actually it's not critical care, it's more to like intensive care unit, intensive care specialists, yeah? They come sit together in 1992, they try to make the sepsis definition more standardized. So this is happened, where is this happened? In Berlin, yeah, Berlin. So what a group of 9 specialists, which is the intensive care specialists, they sit together in one of the villa. Actually, it's after a conference, they have a coffee, and then one of the intensivists, which is J.L. Vincent, Professor J.L. Vincent, and he called upon all these friends, say, come to my villa and then have some coffee, and then Saturday, Sunday, over the weekend, and then we come out a consensus, okay or not. So they come in and sit in together for 2 days. So the definition of first sepsis 1992 was created, was formed. And that time also Mr. Bone, Professor Bone, Dr. Bone, actually have introduced the term SIRS, CAS, and MAS. However, during the sepsis 1 definition, SIRS was heavily emphasized. So in 2000, this panel of people, the 9 of them, unfortunately there's no emergency physician, inside there, so it's all intensivists. So they sit together again, and then was come in again, redefine it, and they add in more criteria on organ failure. So the organ failure, more systematically approach to organ failure that time. So that time, 2001, the first EGDT, which is by River et al., he used the sepsis 2 definition to define patient, and then he come up a protocol, name it EGDT, and then we found that they reduced the sepsis mortality from 40% become 18%, 40 become 18 plus 18. So this paper was tremendously very well known and very famous throughout the whole world. And then the same committee, which is the Sepsis 2 committee, joined with other critical care specialists from other countries. They sit together, form the Critical Care Society, which is a Society of Sepsis Committee. They sit together and use the EGDT as a guide and put in the guideline, SCC guideline 2004. And they revised again in 2008, SCC 2008, and then subsequently until today, SCC 2018. However, because over the last 20 years, the sepsis 2 and sepsis 1 definition miss out a lot of patients. You can imagine a lot of patients who have sepsis ED was discharged, especially those tonsillitis patients, those flu patients with some sign of SIRS. But however, they was discharged after you manage some fluid and given the antibiotic was discharged. So the sepsis 1 and sepsis 2 definition definitely is not as serious and didn't reflect the seriousness of the disease. So this is a problem when they found that the sepsis itself make a lot of people confused, and also it causes a lot of discrepancy in management of patient. So 2016 they start again redefine the sepsis, and then they convert the sepsis, severe sepsis and septic shock become sepsis and only septic shock only. So the sepsis 2016 actually is equivalent to severe sepsis in 2002. Septic shock still remains same. So this time they already introduced qSOFA. But the qSOFA, actually there's a lot of problem with current situation because qSOFA is too simple, but it cannot be used in ICU. So there's a lot of discrepancy in between because they say qSOFA is not sensitive enough to pick up patient. There's a lot of patient sepsis that was missed. So there's a paper say that qSOFA couldn't replace the search criteria. And then now, so they think that qSOFA is not absolutely good. So they reintroduce back the SOFA score again so that they didn't miss the organ failure. Well, however, SOFA score is not user-friendly and it also not really able to use in our chaotic and also fast-paced emergency fraternity. So from here, okay, so this is the roughly, I think everybody know the sepsis 1 definition from Bone, Professor Bone, who already passed away, I think last 3 years ago or 4 years ago. And then this is where our familiar term sepsis defined as SARS plus two or more SARS plus infection. Severe sepsis is SARS with organ failure, and septic shock, SARS-induced hypotension despite adequate fluid. For two SARS criteria, everybody understand, this is 38, 36, I'm not going to repeat. For definition, sepsis 2, same, but they come out a list of definition, more detailed definition, and more parameter for you to monitor, and more organ failure parameter for us to follow. However, it's still a long list, which I think is not popular. And a lot of people won't look into this because it's very clinically experience based. So now they look into sepsis 3. So sepsis 3 is introduced by the group of the same people, but published by Seymour et al. February 2016. So the definition that we define it as sepsis must have life-threatening organ dysfunction caused by dysregulated host response to infection. So there is a word called life-threatening organ dysfunction. Now, sepsis must have life-threatening organ dysfunction and caused by dysregulated host response toward infection. Dysregulated host response means that the inflammation process, the immunity, and the nutrition status, all these respond to infection. So further define septic shock, which is you have to fulfill some of the criteria of sepsis itself, plus persistent hypotension, plus serum lactate more than 2, despite adequate volume resuscitation. Okay, there's some of the difficulty here because serum lactate more than 2. Not every hospital in Malaysia have serum lactate. I think ICU have, but not in it. So I make this chart simple for you. The definition of sepsis now, we have these 3 components, which is infection. Infection can come from bacteria itself, fungi itself, prion itself, virus, and parasite. And life-threatening organ dysfunction, we can assess by these 3 tools. Just now, Dr. Desmond have already mentioned something about qSOFA, about SOFA, and MSOFA. You can either use either one. However, in ICU, you only can use SOFA score as a gold standard to assess the organ dysfunction. Yeah, this is a scoring to objectively score the organ dysfunction. However, for the whole dysregulated response, there is a lot of other factors that we are talking about, like surge. Okay, surge, I think everybody understand what is surge, but I will introduce you some of the new terms, which is CAS and MAS, as well as PICS. Here is the abbreviation. Compensated anti-inflammatory response syndrome, MAS, mixed antagonist response syndrome, and PICS, persistent inflammatory immunosuppressed and catabolic syndrome. I will introduce one by one in the next slide. So, current understanding of sepsis definitely is like a blind man who touching the elephant. When you touch where you think of that is sepsis. The whole, especially the whole dysregulated response. The whole dysregulated response, there is no measurement for you to measure. You cannot visualize. You cannot use X-ray to tell you is the patient in inflammation, hyperinflammation state or hypoinflammation state. Is the patient immunocompromised or not? There is a lot of big things that we need to look into. Okay, why we need to look into this? Because it affects the management and outcome of the patient. It does matter. Okay, let me introduce to you whole dysregulated response in sepsis. So, okay, we are talking about the SIRS, we are talking about CAS, we are talking about MAS, and also the PICS. So we are talking about this chapter here. Yeah. So, okay, I know this chart is a bit fuzzy, but however, I bring you along and just follow me. All right. So, SIRS, CAS. And this is where the inflammation response. Hyperinflammation, hypoinflammation. All right. So, for hyperinflammation, usually any infection. You see, this is a blue line here. There is a blue color line here. This area is called homeostasis curve. This area is above this area is compensating, and if let's say more than this area more, if this area more, this will be a very hyperinflammation, which is decompensated state. All right. So this area surge is considered hyperinflammation. CAS, okay, CAS. What you mean by CAS is compensated anti-inflammatory response syndrome, which the patient come in with hypoinflammation. So hyperinflammation, patient still able to compensate. Follow the black line. Actually, it's a compensated curve. It's a homeostatic curve for a patient who have a normal infection that they can resolve themselves. However, the line who exceed the blue color area actually is patient is trying to compensate with whatever resources they have. They might recover if they have enough resources to compensate. If they don't have enough resources or they are immunocompromised, they might not. They will follow this blue line, they will decompensate and patient will go into shock. And so all infection come in is depend on the patient previous or current health situation. Yeah. So there is a lot of other different. Okay, let's say if a normal patient who have normal inflammation response, they will follow the black colors curve. Yeah. But if the infection is a bit more, or patient himself have a hyperinflammation, such as they have already pre-existing inflammation at their body, meaning that they may have a SLE or they may have a rheumatoid arthritis, and also they might have on some medication to improve their infection, improve their inflammations. Then they will cause a very high infection cytokine, high cytokine. Even in a young patient or male patient on steroid can have a hyperinflammation state. So this patient will come, this is days. So they usually will come in very early with a high grade fever, very hyperinflammation, and then they might have a very ill looking, toxic looking presentation and lethargic. And this also applies to dengue and other infection. Okay, how about this curve? This curve is those who had more they have overly produced inflammation. Some of the patients by default, genetically, they have a very hyperinflamed or sensitive to infection. They will be overly inflamed to protect themselves. Some actually, this response also based on the races. The world races like Caucasian, the black, the colored, and our Asian or Hispanic. They have different type of response, and also the age itself. Young age or patient on immunization, they have a more inflammation more sensitive to inflammation, and they will produce more cytokine. Okay, what kind of patient will come into this curve? when the infection prolonged and the infection was not get rid of it, they can continue with a hyperinflammation because patient already start to exhausted, start to hyperinflame, start to have a lack of resources to produce the inflammation, and then patient will subsequently become cold, hibernate, and later on they will pass away slowly. So maybe an elderly, very senior citizen, they may not respond. They may present it with no SIRS at all, but they will present it with CAS because they have a poor response, inflammational response toward the infection. Or a patient with have chemotherapy, patient already have cancer or chronic diseases, they might come in no response, no SIRS response or little bit of SIRS response, but they will go into the CAS response very fast. And okay, both arms also can cause septic death. So if hyperinflammation, the cytokine itself can cause multi-organ failure, which is due to the cytokine overwhelming, which is like we talked about HLH just now, right? And as well as those leaking on the dengue, this is due to the high pro-inflammatory response. However, for those who have come in here, it's a late day. Late death meaning that patient is exhausted until patient pass away, which is patient cannot fight anymore. The pathogen is too much that the body cannot function and cannot kill the bacteria properly or the virus properly or pathogen properly, or was not treated or didn't seek for treatment, and then they will end up with the pathogen overwhelming and cause the patient multi-organ failure and death. So these two death is totally different perspective of different angle. This is due to your own response. This is due to the pathogenicity and also the poor immune system. Okay, SIRS criteria is the same. So it may during this SIRS criteria, this is a normal SIRS criteria that the cytokine storm, if the fever is more than 38 and above, heart rate is high, respiratory is high, total white can be very high or can be very low. It depends on what kind of infection. Viruses can be low, total white can be high. Especially inside COVID. COVID also can cause SIRS, which it can cause a total white low. Yeah. Okay. Now I want to introduce you a new term. Maybe this term is not new for me, but maybe some of you is new. So what you mean by compensated anti-inflammatory response syndrome? It's very simple. It's like compensated shock. Okay. When we have compensated shock, we have all the vital signs seems normal. Patient, everything seems normal, but however, clinically, patient doesn't look good. However, the parameter like heart rate, blood pressure, everything look normal. But one thing about CAS is that our body actually start to cool down because we have no resources or we don't have any resources to fight back the infection itself. And our body will shut down. Let's say I give you a very simple analogy. Yeah? If infection come into our body, then our body will send all the army go and kill the bacteria or the pathogen. When we kill the pathogen is, if the pathogen very virulent or pathogen have a very high load, and our body keep on fighting for a few days, and then our nutrition status was not taken care of, maybe at the time, day 4 or day 5, the patient start to have lack of energy or lack of all the substrate to support this inflammation, and subsequently the body will tell us that, oh, okay, I cannot fight anymore. How about I want to prolong my life by reserving my resources? I don't want to fight anymore, so I want to prolong my life by using my remaining resources. I close my door. I don't want to fight anymore. I just use this to prolong my life until the end of the life. So I wasn't going to counter my pathogen anymore, let the pathogen stay outside my house. However, we consider this as a inflammation fatigue, or we call it hibernation of the patient. And this is called CAS. So usually the CAS patient will come in with a very, very hypoinflammation, such as like temperature low, severely hypoglycemic. Actually, it's not severe hypoglycemic, it's hypoglycemic. And also patient is low temperature, like hypothermia. Usually they will come in less than 36.5, 36 degrees Celsius. And then they have a very low lymphocyte, very low count on some of the cell line of white cell. And also they have a very poor nutrition status. And the criteria of CAS and SIRS is just very near. is that the criteria of CAS only two. The temperature must be less than 36 or lower, and also the lymphocyte count, absolute lymphocyte count is less than 1.8. This is not a percentage, this is more to the count, yeah? Why? Because the lymphocyte play the most important role in inflammation and infection. So this is the criteria. Why CAS happen? Because we want to conserve ATP. We have a low ATP, we want to conserve the ATP to prolong the life. So that's why if we can measure, hypothermia is indirect measurement of the energy produced by body. And we have low lymphocyte count, we have very low cytokine. If we have, then that's why we have a very low monocyte as well. And we have a decrease in the HLA. HLA is to present the bacteria. Now, because we want to hibernate, we don't want to present more pathogen in the cell to trigger the leukocyte to attack them. So we have low HAL and HLA, and also we have a very low IL-10, which we in overseas they do this test. Yeah, they do this test. Yeah, expression of IL-10 is actually suppress the TNF. Because this is compensated, a lot of anti-inflammatory response is already started because you want to prolong life, you want the inflammation to cause more harm, cause more cell death. So you say IL-10 have to increase to suppress the destruction of the normal cell to prolong your life. So I did explain about SIRS and I did explain about CAS. Okay, how about when the modern medicine, our modern medicine advancement and prolong the life of patient by giving the life support like ventilator, like giving antibiotic, like giving food, like giving nutrition via TPN. And actually this will give nutrition support to the patient and prolong the patient life. However, if the pathogen was not eradicated, if we support the patient wider substrate for them to prolong their life, actually we are prolonging their life without fighting the pathogen, without elicit the pathogen. Then it will enter a state called PICS, persistent in immunocompromised, yeah, or catabolic state. Yeah, okay. This PICS actually started after advancement of our ICU setting. A lot of pathogen we weren't able to we weren't able to get what is the source of infection, and this infection most likely is more to viral in nature. As you know that viral infection, actually there is not much of choice of antivirals that are available in our market, and it actually couldn't kill. It couldn't kill the bacteria or viral. It couldn't kill the viral if they reactivate. So the pathogen will keep on persistent there. However, we support the patient body by giving TPN, by giving all the support on the nutrition and also the support of ventilation that prolong the life and cause the patient in the PICS situation. Okay, this is roughly a chart for you to see whether these SIRS must either must high, the temperature can be high or low, total white may high or low. CAS can be normal or high heart rate, can be normal or high respiratory rate, must be low temperature and low total white. Okay, in between transition period of SIRS to CAS, we call it the MAS. It's a transition period of when the patient start to exhaust from SIRS want to become CAS, they become MAS. So it's a mixture of both. Majority of a patient here is MAS patient. You see this chart. This is MAS. It's called mixed antagonist response syndrome. It's a mixture of SIRS and CAS. However, majority of this type of patient, usually their SIRS criteria is not positive. Maybe they have one criteria positive like tachycardic only, but temperature normal, no fever, nothing, all right? And CAS inverse, no fever. So that's why if we use a conventional definition of our sepsis, we only can catch this group of patients. Remember, our sepsis 1 and sepsis 2 definition is infection with SIRS only, right? But how about this group of patient and this group of patient which presented majority to our emergency department and we miss it because they didn't fulfill the SIRS criteria, then they was not labeled as sepsis. But however, they are more ill than the SIRS patient. Okay, so this is what the PICS means. Persistent inflammation, immunosuppressed, and catabolic syndrome. This is more to a stage of immunoparalyzed because the patient inflammation totally zero, yeah? but they have, no, sorry, it's not today, it's low-grade inflammation. Just sustain for them to prolong their life, because we have a lot in ICU intervention, as I said, and this produce a characteristic state of the patient inflammation, because we support the nutrition without tackling the infection source. So, so from this chart, okay, I know that this chart is a bit fuzzy, as always I say, okay, but I just share with you, just look at these three words: cellular immunity, humoral immunity, inflammatory response. So for a normal person, who a normal human being, they have these three systems in place when we born. However, when born is only cellular immunity is more how which is our neutrophil that protect us, and inflammatory response protect us. Humoral immunity is by age. When we got influenza, we got infection, then we start to have antibody. This is more the adaptive type immunity. The more dirty you are, the more humoral immunity you are. This is what I always say. Yeah. So the more when you are more aware, avoid all this exposure, actually you will harm this. No humoral immunity at all. So these three is interrelated, which was controlled by the T register cell. T cell is a lymphocyte. Yeah. Lymphocyte, you see, T helper cell, T cell, all this is all lymphocyte. You just need to know lymphocyte. Okay, can you see if the lymphocyte is low, the whole pathway was really disturbed, right? Especially the T cell. Now, if the T cell not enough, T helper cell, T helper 2, T helper 17, all will retard, and then all your immunity will be destroyed. How about if T cell very hyperactive? Everything will hyperactive as well and cause a lot of cytokine. Remember, this square cell actually is more to antigen presenting cell. The word is so bombastic, actually it's simple for you. It's monocyte. Yeah, monocyte that combine with lymphocyte and produce, activate the neutrophil. Yeah, as neutrophil or leukocyte. And this combination also stimulate the lymphocyte to the B cell to produce antibody, and also to stimulate the T cell to come out cytokine. So if you understand this chart, very simple, if any of this cell was infected or attacked by our pathogen, or we have no nutrition to produce this cell, our immune system gone. And these three cell lines should be together to fight, to produce as a complete immunity. Yeah? If either one of these was not able to function, such as like inflammation response not functioning because of poor protein intake, not enough protein, so no much of inflammation. So these two also consider this patient with loss of inflammatory response. This is called immunocompromised. Or if you have humoral immunity gone, meaning that some of the infection can attack the T cell or B cell and cause the T cell dysfunction, and then lack of IgG, IgM, or patient poor nutrition, they cannot produce IgG, IgM and so this cell line gone. If this cell line gone, this patient also considered as immunocompromised. Like COVID-19 actually, this cell line is low. This cell line, the T cell is low. When they're low, all these three, more to this three is immunocompromised. And then, or the other, some of the like chemotherapy, we kill off the natural cell, which is our macrophage, our phagocyte. The chemotherapy causes neutropenic sepsis, remember? So this cell line gone. So only these two cell lines. So they also consider as immunocompromised. Okay, these three cell line, either one retard or inhibited, patient is immunocompromised. However, which is more serious? If the neutrophil is gone, the patient will pass away very fast. Especially you see neutropenic sepsis is so serious, right? It will cause harm to the patient. And it will kill the patient. Mortality is high. However, if the humoral immunity is impaired, however, this is intact, but the humoral immunity is impaired, patient can survive because we still got this cellular immunity to protect us. However, this will cause a lot of sepsis. It will present to our ED with sepsis and also partially immunocompromised, or we call it immunocompromised, which is we didn't detect it. That's why I'm talking about this. Why? Because we want to look into ALC. The absolute lymphocyte count is very important in our sepsis infection and any infection disease. So So this is, if let's say this is gone, our whole body definitely is in the immunocompromised state. Then our body will go into CAS phase very fast because we want to fight the infection, because we don't have any nutrition to fight and we don't have any way to recover. We need support. Okay, this is the PICS criteria. The PICS criteria must have prolonged hospital stay more than 14 days. Yeah, actually it's 14 days and more. C, reactive protein must have persistent 150 microliter, or here is about 15 CRP, and absolute total lymphocyte count is 0.8. 0.8, not 800 per millimeter cubic is 0.8. I mean, if you see ALC in our ED here, if the ALC is absolute lymphocyte count is 0.8 and below, patient is PICS. Patient also have albumin low, less than 30. Remember just now we shared with you the previous patient who passed away, the CPR patient. Actually, he have albumin less than 30. He's hypothermia. He have a CRP of more than 15. Yeah, and then and also he had, I don't know whether he had weight loss or not, and also retinal binding we couldn't find. But patient definitely in the PICS state at least, or CAS state at least. But because we didn't show you the lymphocyte count. The patient lymphocyte count is 0.5, if I'm not mistaken, absolute lymphocyte count. So it's PICS actually. But he didn't fulfill this 14 days. So this chart is more complicated, but I think I combine everything as a sequelae of each patient come in. Let's us follow the green line. Yeah, this green line is a normal infection patient, and then between 7 days to 10 days, they should follow this line and recover. All right. However, in a special group of patients, very young age, patient very colored skin, and also Caucasians or Arab descendants, as well as some patients who have pre-immune states like SLE, yeah, or something, they will follow this curve, the dotted line. So they might come in with a first infection curve, okay? So they will hyperinflame a bit, and then they recover at day 10. However, unfortunately, because they started antibiotic or something, but actually it's more the viral, and or patient because of a very hyperinflamed patient, a bit exhausted but still coping. Second time of infection come in, because the first insult, patient not yet recover, give them a chance to get a second time infection. Very typically for elderly who come in or admitted to ward for 1 week ago, presented again to our ED again for pneumonia or something for second time infection, which is this curve. So this curve is keep on repeating until it entered this CAS phase. You see here, SIRS phase. The second time infection, they won't give you the typical SIRS anymore. They give you a mask, a mixture of both. The third time infection between the first same month or 3 months, between the 3 months, you give you a CAS. Meaning that patient no more able to fight. So meaning that they can go further from here, and then go to this blue line and pass away. Or a patient who have very ill or very maybe patient has cancer or pre-morbidly immunity is not good, they might follow this green line, and then they follow the blue line, and then keep on. There's no inflammation anymore. Patient vital signs look normal, but patient ill. Yeah. However, if this curve persists more than 14 days, we already said either is hyperinflammation or hypoinflammation patient is already in PICS. So PICS is just the day that we find it actually. Yeah, prolonged infection, prolonged SIRS, prolonged CAS, prolonged MAS can give you a PICS after 14 days and above. Yeah. So MOD. So if you have hyperinflammation, MOD can happen here, can happen here as well. Especially this is the first stage. This is the point where you have to remember if hyperinflation can cause early death, yeah, and also organ failure, and also organ failure started here after you cannot compensate, yeah, and also septic shock and sepsis and septic shock started here when you have this point. Why I say so? Because here usually patients have already either they recover or either they have organ failure, right? So now I will move on to the infections, the whole dysregulation response to life-threatening organ dysfunction. Now I'm talking about organ dysfunction. Yeah, Just now, we not talk about the inflammation that can lead to this organ dysfunction and subsequently cause patient die. Okay, how a patient sepsis die? Patient sepsis die because of organ failure. Okay, so if there is not present of any organ failure, patient won't die. Even inflammation, in fact, inflammation won't cause a patient death. But if inflammation cause organ failure happen, and it will lead to sepsis death. So inflammation is quite easy. You can regulate the inflammation by giving proper drug. Nowadays, you see COVID. During the COVID, there is an interleukin inhibitor. All these things can help in hyperinflammation. So we go back to this chart again. This chart is life-threatening organ dysfunction, the qSOFA, MSOFA, and SOFA. I'm talking about these three. Okay, so the SOFA score actually quite some time already was created by J.L. Vincent, the Professor J.L. Vincent, which is introduced on 1994, published already. And this score is called sepsis-related organ dysfunction, organ failure assessment, and then was subsequently changed to sequential organ failure assessment score, name change. And then after that, they will give the score of 0 to 4, total of 6 organs, 6 times 4 is 24 in maximum. Each of the score will give you a very, to calculate the mortality rate according to the scoring. So, advantage of this SOFA score is you can understand that what lead to the organ failure, which organ is failed, yeah, and understand the nature of the organ failure and how severity and sequelae of the organ failure, and also to assess the effective of your therapy towards each targeted organ failure. And the scoring, if you targeted the organ failure with a proper treatment, the score on proper organ can improve. Yeah. So this is what we shared just now about the SOFA score, which is 1, 2, 3, 4. Okay, if let's say normal is 0, yeah, 0 is more than 400, which is very. So they divide into 6 organs: the respiratory, coagulation, liver, cardiovascular, central nervous system, and renal. However, SOFA score can be easily scored in our ICU, but from ED is a big task for us because we need to have a blood test. Respiratory need blood test, blood test, liver, and also renal. We only have 2 bedside clinical assessment. Yeah, so total 4 blood and 2 clinical assessment. And this was used as a gold standard for now to assess the organ failure. However, a lot of countries cannot apply this, especially in low-income country. They are unable to give you all this investigation properly, proper. So that's why we need to think of other alternatives. Now I introduce to you a modified sepsis-related organ failure, MSOFA. This was validated by Grimson et al. Actually, they use it for the pre-hospital care during the disaster. So they created this modified SOFA score, only required 1 lab laboratory with 4 clinical parameters. It's easy to use, and I think this is quite suitable for the use in Malaysia, especially in ED. You see the comparison of SOFA score and modified SOFA score. Modified SOFA only involves 5 organs, and the score is 4 times 5 is 20, and the mortality rate is equal to SOFA score. And you can see the respiratory is using SpO2 versus FiO2, which you can assess via your SpO2 machine and also the FiO2. And as well, the liver, you can only see whether it got jaundice or no jaundice, 0 or 3 marks. Yeah. And also cardiovascular hypertension is bedside, and CNS with GCS is also bedside. Renal creatinine, this is the only blood that we need to really measure. Yeah. So it's very easy, and the sensitivity specificity same like SOFA score, and can be used in our ED here. So this is what I have modified the whole thing and suit to our local use. The unit SI I changed to suitable for Malaysian use. So you can print this chart actually, and you can circle out for each patient who come to ED, and then later on you can circle again this chart, assess again this chart after 6 hours of your treatment. And you see the mortality for MSOFA 0 to 7 score is about 4%, and SOFA score is 0.7 is 0 to 7 is 5. It's about same, yeah. 8 to 11 is 31, and this 28, and this 1 to 11 is higher, yeah. Why MSOFA higher? Because the score is lower. So if you have a higher score, less scoring system, so definitely the percentage should be higher. So it means that this is very useful and very simple for us to used in ED. Yeah. So qSOFA. Okay, what is this qSOFA? Actually, qSOFA is for us to assess organ failure faster, not for us to use as a criteria to define sepsis. Yeah. So this qSOFA actually combine on outer mental status, fast respiratory rate, and low blood pressure. Any two of these will consider suggest poor outcome and suggest there is organ failure. However, this is very specific and less sensitive because to have 2 out of 3 sure patient very high mortality. If 1/2 means that if 1 over the other 3, 1 positive, 2 another 2 negative, it still warranted you to do a SOFA score or MSOFA. Even though it's zero qSOFA, you still need to do a MSOFA or SOFA score because this is for screening, but screening is not useful because we need sensitive. We rather than use a specific two. However, because of this score is so simple, it consists of 3 parameters. It's easy to use in triage and help us to triage in the primary survey, primary triage and secondary triage. Even we can have a simple assessment for a patient without any blood test. However, a gold standard to confirm organ failure must have SOFA score or MSOFA score. Yes, anything? Do you want to ask something? Okay. Sorry? Okay. Can somebody mute the... Okay, can anyone mute the mic? Right? Okay. So I continue. Right. So we did use the qSOFA because of due to the qSOFA dilemma. We had done a systematic review and meta-analysis on qSOFA for the whole world. Then we have published it in 2018 in scientific report, which is in Nature Production. Yeah. So what happened is that we know that actually qSOFA is able to predict short-term and long-term mortality in patients with sepsis, outside ICU. So the result shows that short-term mortality, which is less than 28 days, the SN and SP for qSOFA is this 48% and 86% for SP. For long-term mortality, which is 1 year, so there's 3 studies only. The sensitivity and specificity is 32 and 92. Overall, qSOFA shows poor sensitivity, but very moderate to high specificity. This is the paper that we include into the study. Yeah. So total of 36 paper. So also we count the odd ratio for the short term is 5.6-fold. Whoever have 2 marks and above have higher mortality compared with those have less than 2 marks for 5-fold. Okay, and for long term, which is also 4.6. Whoever have 2 marks and above have 4 and 4.6 times of mortality compared with those have only less than 1, less than 2 or 0. Yeah. So overall, odd ratio is 5.48. So qSOFA actually shows quite a good prediction on long-term mortality. Yeah. However, we also do some sub-analysis for geographical variance because we feel that the races of human have different type of prediction of organ failure because the organ failure can be due to the inflammation response and can be due to the nutrition support and what we eat daily diet. So we found out that for the colored race, actually they have an odd ratio of 8.4, very high on organ failure if you have qSOFA of more than 2. However, for Central America, Europe, and Oceania, this is more to the Caucasian. They have a mean of 5.4. So this is quite a significant difference. And surprisingly for Asian, the odd ratio is very low. And we compare these 3, we have a roughly of homogeneous, have a heterogeneity of 0.05, meaning that we might have a trend of actually colored and Caucasian and Asian have a different type of organ failure presentation, and this also show that maybe a colored have less tolerate, less robust when facing the sepsis, and they have higher mortality rate when they have sepsis compared with Caucasian and compared with Asian. So meaning that Asian can survive longer in sepsis and they can really balance up the immunity and the food intake. So from here we can see actually raise this matter in sepsis prediction and mortality. You see immunity, or we call it the IgG, IgM, is more to protein bound. Yeah, inflammation, cytokine is all protein and also lipid. You can imagine usually our colored friends, they have more bulky and protein, more bulky muscle, and also our Caucasian friend have a lot of muscle, but they have more fat. That's why this reflects that our colored friends have a very good immunity and very hyperinflamed when they have this infection, but because of the less fat and less reserve, that maybe that couldn't support them for longer period of mortality. Compared with our Caucasian friend, they have a very good muscle bulk, however, they have good reserve of fat composition because of the diet of a lot of starch as well. And they can pull through, but they pull through with a very ill outcome because their organ failure usually is quite tremendous, because they pull through because of they have a lot of reserve maybe, and that's why the outcome is not so good. For Asian, we have balance. We have good protein, not too good, fat also not too good, everything not too good, but because we have a lot of starch, you see. So our inflammation is quite gentle, gentle, and also we won't give so much organ failure compared with other races. So that's why it also reflects that Asian races usually they can survive throughout the world in a very extreme places. Okay, for a man and for a female as well, because the muscle bulk and the fat composition is different. Actually, there is a difference as well. So men usually come in day 1, day 2, especially you see dengue patient. They will come in day 1, day 2, day 3, especially men. For women, they will come in day 4, day 5, day 6 because the inflammation is not so, they are more gentle, so they have less fever, less symptom. More inflammation, more pain. More pain, more overly presented, more dramatic, more emotional involved. So you can see, actually from genetic, it affects the culture of each geographical region. It actually reflects that genotype definitely define the culture. Yeah, some people will have more, more overly produced emotion because pain receptor, to just highlight just a few more slides. So this is recently published 2019 by the group Seymour again. Seymour is the one who defined the JAMA, defined the qSOFA. So they subdivide the patient into alpha, beta, gamma, and also delta phenotype. Actually, it confirmed our finding on our publication last time for the races. Actually, an alpha phenotype is those commonest patients who have sepsis with lowest administration, lowest vasopressor. This group actually is a common patient without any hyperinflammation. Okay, the beta group is more to older patients who are more to CAS and they come in with renal failure. And the gamma actually is more to those who are young men, the colored skin, they have more inflammation, cytokine storm, and cause pulmonary dysfunction, more to ARDS, like the cases just now we discussed, the case with coming in pulmonary hypertension, ARDS. Remember, ARDS got two types, yeah? One is hyperinflammation, the other type is hypoinflammation ARDS. Later I'll talk about it. And also the delta type, which is the liver function, this is more to patients who have comorbid, yeah? They have a liver dysfunction more. So actually those, this is more older patient, this is younger patient, this is our common patient, this is who have comorbid, yeah? And gamma seems to only, why people say about oligo-directed therapy is not good, because they combine all 4 phenotypes together using the oligo-directed therapy. However, in this paper, they highlight the gamma group, the delta group actually not benefit for oligo-directed therapy. Because EGDT can kill them more because of liver failure. They have a liver problem. And also increase of alpha phenotype suggests benefit from EGDT. The common type, which is alpha type, actually is benefit for oligo-directed therapy. Yeah, this is very shocking and this is very good. That explain more why EGDT not apply to everybody. That's why now even more we want to highlight personal therapy. We have to determine the patient infection status. We have to determine the patient how dysregulated the inflammation response. Then only we can see whether patient is able to benefit for the treatment or not. So this is a summary of, this one will be presented next time, but I just give you a highlight first. If let's say you can identify the patient in first phase, then maybe you have to start with the septic bundle. All patients with sepsis, you have to start the 1 hour bundle, which is antibiotic, methotrexate, and then vasopressor. However, for the SIRS patient, we need to have personalized therapy, which is more suppressive and nutrition support. Means that if patient in hyperinflammation state, like COVID patient, we have this ARDS, hyperinflammation ARDS, we need to start the interleukin and anti-interleukin. Or we might think of NSAID. You know, Italy was saying that NSAID is good. For Asian, NSAID is not good because of their different nature of presentation. That's why NSAID is contradict in certain genotype, which we have to be careful on this. But our NSAID for Asian might useful, might not, depend on how. And glycocalyx dysfunctions is another thing I will discuss later next time. And also feeding. Our ED here, feeding is a problem because we never start feeding within 6 hours. Feeding is the most important support for the whole process of infection. And glucose must be 8 to 10. Less than 8 to 10 is hypoglycemia. More than 10, actually 8 to 10 or 8 to 12. More than 12 is hypoglycemia. You need to tackle the glucose. If less than 8 is hypoglycemia, we need to give sugar. Okay, not 5 or not 4, it's 8. For those people who come in with MAS, CAS, and PICS, which is immunocompromised on this group, we are more to supportive. We need to give the hormone replacement, we need to give some steroid, we need to give some antibiotic, we need to correct the albumin, because albumin will cause osmolarity low if you're hypo. And also antibiotic was bound in albumin. If not good, then the antibiotic is not functioning. And consider our lactate level. For this group of patients, lactate will be very extremely low. For this group of people, lactate will be extremely high. But a lot of people didn't talk about this lactate, extremely low lactate, because they think that there's nothing significant. Actually, there is a very significant physiology behind the lactate low. Why lactate is low in sepsis with dysregulation? Because lactate high is because hypoxia. Lactate low is because hypoxia or low in sugar. Because no substrate to convert into pyruvate, no lactate. Less than 1 is starving. Patient starving, how to fight infection? So less than, I consider less than 1 is very critically hyponutrition patient. We need to tackle the lactate by give some sugar and give some insulin for the patient. Yeah. Okay, take home message today. I think we will talk about the quick identification, the sepsis, the septic shock, and then determine the SIRS, CAS, MAS, PICS, and then also we have to talk about some of the biomarker later next time, and then this one will be the next webinar. Next webinar will be next Tuesday also at 9 o'clock until 11. I will talk about the hemodynamic monitoring and as well as management. So thank you. So I will open this to the floor to ask any questions that you want. Yeah, please.